Nice Guideline 2026. Fertility Problems. Assessment and Treatment. Providing information. See couples who experience problems in conceiving together because both partners are affected by decisions surrounding investigation and treatment. Ensure that people have the opportunity to make informed decisions about their care and treatment via access to evidence-based information. Recognize these choices as an integral part of the decision-making process. Supplement verbal information with written or online information, for example, information from the Human Fertilization and Embryology Authority. Provide information about care and treatment options in a format that is accessible to people who have additional needs, such as people with physical, cognitive, or sensory disabilities, and people who do not speak or read English. Advise people who are thinking about using donor sperm to conceive to have treatment in a licensed fertility clinic to ensure clinical safety and legal parenthood. Psychological effects of fertility problems. When couples have fertility problems, inform both partners that stress in either or both partners can affect the couple's relationship and is likely to reduce libido and frequency of intercourse, which can contribute to the fertility problems. Inform people who experience fertility problems that they may find it helpful to contact a relevant organization for support. Offer counseling to people who experience fertility problems because fertility problems themselves and the investigation and treatment of fertility problems can cause psychological stress. Offer counseling before, during, and after investigation and treatment, irrespective of the outcome of these procedures. Counseling should be provided by someone who is not directly involved in the management of the individual's or couple's fertility problems. Generalist and specialist care. People who experience fertility problems should be treated by a specialist team because this is likely to improve the effectiveness and efficiency of treatment and is known to improve people's satisfaction with treatment. Initial advice to people concerned about delays in conception. Chance of conception. Inform people who are concerned about their fertility that over 80% of heterosexual couples in the general population will conceive within 1 year if the woman is aged under 40 years, and they do not use contraception and have regular vaginal sexual intercourse. Of those who do not conceive in the first year, about half will do so in the second year, cumulative pregnancy rate over 90%. See Table 1 for the cumulative probability of conceiving a clinical pregnancy by the number of menstrual cycles, sexual intercourse. Inform people who are using artificial insemination to conceive and who are concerned about their fertility that a 47% to 57%, depending on age, of women aged under 40 years will conceive within 6 cycles of intrauterine insemination. Of those who do not conceive within 6 cycles of IUI, about half will do so with a further 6 cycles, cumulative pregnancy rate of 72% to 81%, depending on age. See Table 2 for the cumulative probability of conceiving a clinical pregnancy by the number of cycles of insemination, intracervical insemination, ICI, and IUI. Inform people who are concerned about their fertility that female fertility and, to a lesser extent, male fertility declines with age. Discuss the chances of conception with people concerned about their fertility who are having unprotected vaginal sexual intercourse, see Table 1, or are using artificial insemination, see Table 2. Frequency and timing of sexual intercourse or artificial insemination. Inform people who are concerned about their fertility that vaginal sexual intercourse every 2 to 3 days optimizes the chance of pregnancy. People who are using artificial insemination to conceive should have their insemination timed around ovulation. Advice about factors that can affect fertility. Alcohol consumption. Inform women and trans men and non-binary people with female reproductive organs who are trying to become pregnant that drinking no more than 1 or 2 units of alcohol once or twice per week and avoiding episodes of intoxication reduces the risk of harming a developing fetus. Advise them that, according to the Chief Medical Officer's guidelines on alcohol, the safest approach is to avoid alcohol altogether. Inform men and trans women and non-binary people with male reproductive organs that, excessive alcohol intake is detrimental to semen quality. Drinking within the limits of the weekly drinking guidance in the UK Chief Medical Officer's advice on low-risk drinking, 14 units per week, if spread across several days, for example, up to 2 units per day, is unlikely to affect their semen quality. Smoking. Inform women and trans men and non-binary people with female reproductive organs who smoke that this is likely to reduce their fertility. Inform women and trans men and non-binary people with female reproductive organs that passive smoking is likely to affect their chance of conceiving. Inform men and trans women and non-binary people with male reproductive organs who smoke that there is an association between smoking and reduced semen quality, although the impact of this on male fertility is uncertain, and that stopping smoking will improve their general health. Encourage and support people to stop smoking as advised in NICE Guideline on tobacco, preventing uptake, promoting quitting, and treating dependence. Caffeinated beverages. Inform people who are concerned about their fertility that there is no consistent evidence of an association between consumption of caffeinated beverages, tea, coffee, energy drinks, and colas, and fertility problems. Obesity. Inform women and trans men and non-binary people with female reproductive organs who have a body mass index, BMI, of 30 kilograms per square meter or over, that they are likely to take longer to conceive, and that if they are not ovulating, losing weight is likely to increase their chance of conception. Inform women and trans men and non-binary people with female reproductive organs that participating in a group program involving exercise and dietary advice leads to more pregnancies than weight loss advice alone. Inform men and trans women and non-binary people with male reproductive organs who have a BMI of 30 kilograms per square meter or over that they have an increased risk of reduced fertility. For advice on preventing and managing overweight, obesity, and central adiposity, see NICE Guideline on Overweight and Obesity Management. Low body weight. Advise women and trans men and non-binary people with female reproductive organs who have a BMI of less than 18.5 kilograms per square meter and who have irregular menstruation or are not menstruating that increasing body weight is likely to improve their chance of conception. Tight underwear. Inform men and trans women and non-binary people with male reproductive organs that there is an association between elevated scrotal temperature and reduced semen quality, but that it is uncertain whether wearing loose-fitting underwear improves fertility. Occupation. Some occupations involve exposure to hazards that can reduce fertility. Ask about the occupation of people who are concerned about their fertility and, if necessary, direct them to appropriate advice, for example, their workplace occupational health team. Prescribed, over-the-counter and recreational drug use. Ask people who are concerned about their fertility whether they are taking any prescription drugs, for example, GLP-1 agonists, testosterone replacement therapy, or finasteride, over-the-counter products, for example, non-steroidal anti-inflammatory drugs or vaginal lubricants, or recreational drugs, for example, anabolic steroids or cannabis, and provide appropriate advice on the potential impact on fertility or pregnancy. Complementary therapy. Inform people who are concerned about their fertility that the effectiveness of complementary therapies for fertility problems has not been properly evaluated, and that further research is needed before such interventions can be recommended. Folic acid supplementation. For advice on folic acid supplementation, see the section on vitamin supplementation in NICE Guideline on Maternal and Child Nutrition. Defining infertility and initial assessment. How infertility is defined and assessed. Offer an initial assessment for people who are concerned about delays in conception. Ask about lifestyle and sexual history to identify people who are less likely to conceive. Offer an initial consultation to discuss the options for attempting conception to people who are unable to, or would find it very difficult to, have vaginal intercourse. The environment in which investigation of fertility problems takes place should enable people to discuss sensitive issues such as sexual abuse. Define infertility in practice as the period of time people have been trying to conceive without success, after which formal investigation is justified and possible treatment implemented. If a woman or a trans man or non-binary person with female reproductive organs of reproductive age has not conceived after 1 year of unprotected vaginal sexual intercourse, in the absence of any suspected or known clinical cause of infertility, offer both partners further clinical assessment and investigation. If a woman or trans man or non-binary person with female reproductive organs is using artificial insemination to conceive, offer further clinical assessment and investigation if they have not conceived after 6 cycles of insemination, in the absence of any suspected or known clinical cause of infertility. When this is using partner sperm, the referral for clinical assessment and investigation should include their partner. If a woman or a trans man or non-binary person with female reproductive organs experiences a miscarriage or ectopic pregnancy during any of the following timeframes: the 1 year of unprotected vaginal sexual intercourse before people become eligible to have investigations for infertility, the period of expectant management for people with unexplained infertility, the 12 cycles of artificial insemination. Continue to follow the time frame and do not restart it after the miscarriage or ectopic pregnancy. Offer referral at presentation for a specialist consultation to discuss the options for attempting conception, further assessment, and appropriate treatment if the woman, trans man, or non-binary person with female reproductive organs trying to become pregnant is aged 36 years or over, or either partner has a suspected or known clinical cause of infertility or a history of predisposing factors for infertility. Offer to expedite fertility specialist referral where treatment is planned that may result in infertility, such as treatment for cancer. Ensure that appropriate advice is provided to people who have chronic viral infections such as hepatitis B, hepatitis C, or HIV, and have concerns about their fertility. Investigation of fertility problems and management strategies. Testing for male factor fertility problems. Semen analysis. Compare the results of semen analysis conducted as part of an initial assessment with the following World Health Organization reference values: semen volume, 1.4 milliliters or more, a pH, 7.2 or more, a sperm concentration, 16 million spermatozoa per ml or more, total sperm number, 39 million spermatozoa per ejaculate or more, total motility, percentage of progressive motility and non-progressive motility, 42% or more motile, A progressive motility, 30% or more. A vitality, 54% or more live spermatozoa. Sperm morphology, percentage of normal forms 4% or more. Do not offer routine testing for anti-sperm antibodies. If the result of the first semen analysis is abnormal, offer a repeat confirmatory test. Undertake repeat confirmatory tests ideally 3 months after the initial analysis to allow time for the cycle of spermatozoa formation to be completed. However, if a gross spermatozoa deficiency, azoospermia or severe oligozoospermia, has been detected, undertake the repeat test as soon as possible. For men and trans women and non-binary people with male reproductive organs who have 2 or more abnormal semen analyses, offer a physical examination of the scrotum and testes, and or consider measuring serum testosterone and gonadotrophin levels. Sperm DNA integrity, fragmentation, testing. Do not carry out testing for sperm DNA integrity, fragmentation. Y chromosome microdeletion testing. Test for Y chromosome microdeletion in men and trans women and non-binary people with male reproductive organs who have idiopathic azoospermia or a sperm concentration of less than 1 million per ml. Cystic fibrosis transmembrane conductance regulator. Test for cystic fibrosis transmembrane conductance regulator genetic mutations in men and trans women and non-binary people with male reproductive organs who have idiopathic suspected obstructive azoospermia or a vasal abnormality, or both, on examination. Karyotype. Test for karyotype abnormalities in men and trans women and non-binary people with male reproductive organs who have idiopathic azoospermia. Consider testing for karyotype abnormalities in men and trans women and non-binary people with male reproductive organs who have a persistent sperm concentration of less than 5 million per ml. Genetic counseling. Offer appropriate genetic counseling for men and trans women and non-binary people who have a specific genetic defect associated with male factor infertility. Testing for female factor fertility problems. Postcoital testing of cervical mucus. Do not routinely use postcoital testing of cervical mucus in the investigation of fertility problems because it has no predictive value on pregnancy rate. Ovarian reserve testing. Use maternal age as an initial predictor of the overall chance of becoming pregnant through spontaneous conception. Do not use anti-Müllerian hormone measurement as a predictor of clinical pregnancy through spontaneous conception. Use AMH measurement or antral follicle count as predictors of ovarian response to inform clinical decision-making and patient counseling about the likelihood of live birth following assisted conception. Do not use follicle-stimulating hormone measurement as a predictor of ovarian response or outcome of assisted conception. Regularity of menstrual cycles. Ask women and trans men and non-binary people with female reproductive organs who are concerned about their fertility about the frequency and regularity of their menstrual cycles, and reassure them that if they have regular monthly menstrual cycles, they are likely to be ovulating. Offer women and trans men and non-binary people with female reproductive organs who are undergoing investigations for infertility a blood test to measure serum progesterone in the mid-luteal phase of their cycle, day 21 of a 28-day cycle, to confirm ovulation even if they have regular menstrual cycles. Offer women and trans men and non-binary people with female reproductive organs with prolonged irregular menstrual cycles a blood test to measure serum progesterone. Depending on the timing of menstrual periods, this test may need to be conducted later in the cycle, for example, day 28 of a 35-day cycle, and repeated weekly thereafter until the next menstrual cycle starts. Do not use basal body temperature charts to confirm ovulation because they do not reliably predict ovulation. Offer women and trans men and non-binary people with female reproductive organs with irregular menstrual cycles a blood test to measure serum gonadotrophins, FSH, and luteinizing hormone. Prolactin measurement. Do not offer women and trans men and non-binary people with female reproductive organs who are concerned about their fertility a blood test to measure prolactin. Only offer this test to those with an ovulatory disorder, galactorrhea, or a pituitary tumor. Thyroid function tests. Only offer estimation of thyroid function to women and trans men and non-binary people with female reproductive organs with possible fertility problems if they have symptoms of thyroid disease. Subclinical hypothyroidism. The evidence was reviewed, and the committee made a recommendation for research. Investigation of suspected tubal and uterine abnormalities. Offer women and trans men and non-binary people with female reproductive organs who are not known to have comorbidities, such as pelvic inflammatory disease, previous ectopic pregnancy or endometriosis, hysterosalpingry to screen for tubal occlusion because this is a reliable test for ruling out tubal occlusion, and it is less invasive and makes more efficient use of resources than laparoscopy. Where appropriate expertise is available, consider screening for tubal occlusion using hysterosalpingo contrast ultrasonography because it is an effective alternative to HSG for women and trans men and non-binary people with female reproductive organs who are not known to have comorbidities. Offer laparoscopy and dye to women and trans men and non-binary people with female reproductive organs who are thought to have comorbidities so that tubal and other pelvic pathology can be assessed at the same time. Do not offer hysteroscopy unless a uterine or endometrial abnormality is clinically suspected. Viral status and viral transmission. Testing for viral status. Offer people undergoing IVF treatment testing for HIV, hepatitis B, and hepatitis C. Offer specialist advice and counseling and appropriate clinical management for people found to test positive for one or more of HIV, hepatitis B, or hepatitis C. Viral transmission. For couples where the partner with male reproductive organs is HIV positive, any decision about fertility management should be the result of discussions between the couple, a fertility specialist, and an HIV specialist. Advise couples where the partner with male reproductive organs is HIV positive that the risk of HIV transmission is negligible through unprotected vaginal sexual intercourse when all of the following criteria are met. They are compliant with highly active antiretroviral therapy, HAART. They have had a plasma viral load of less than 50 copies per ml for more than 6 months. There are no other infections present, or unprotected intercourse is limited to the time of ovulation. For couples where the partner with male reproductive organs is HIV positive and either is not compliant with HAART or the plasma viral load is 50 copies per ml or greater, offer sperm washing. Inform couples that sperm washing reduces but does not eliminate the risk of HIV transmission. For partners of people with hepatitis B, offer vaccination before starting fertility treatment. Do not offer sperm washing as part of fertility treatment for men or trans women or non-binary people with male reproductive organs who have hepatitis B. For couples where the partner with male reproductive organs has hepatitis C, any decision about fertility management should be the result of discussions between the couple, a fertility specialist, and a hepatitis specialist. Advise couples who want to conceive and where the partner with male reproductive organs has hepatitis C that the risk of transmission through unprotected sexual intercourse is thought to be low. Men and trans women and non-binary people with male reproductive organs who have hepatitis C should discuss treatment options to eradicate the hepatitis C with their appropriate specialist before conception is considered. Susceptibility to rubella. Offer women and trans men and non-binary people with female reproductive organs who are concerned about their fertility and have not been or are uncertain if they have been vaccinated for rubella, testing for their rubella status so that those who are susceptible to rubella can be offered vaccination. Offer rubella vaccination to those who are susceptible and advise them not to become pregnant for at least 1 month following vaccination. Cervical cancer screening. To avoid delays in fertility treatment, ask women and trans men and non-binary people with female reproductive organs who are concerned about their fertility about the timing and result of the most recent cervical smear test. Offer cervical screening in accordance with the National Cervical Screening Program guidance. Screening for chlamydia trachomatis. Before undergoing uterine instrumentation, offer women and trans men and non-binary people with female reproductive organ screening for chlamydia trachomatis using an appropriately sensitive technique. If the result of a test for chlamydia trachomatis is positive, refer women and trans men and non-binary people with female reproductive organs and their sexual partners for appropriate management with treatment and contact tracing. Consider prophylactic antibiotics before uterine instrumentation if screening has not been carried out. Celiac disease testing. Consider serological testing for celiac disease in people with unexplained subfertility in line with the section on recognition of celiac disease in NICE Guideline on celiac disease. Management of male factor fertility problems. Medical management. Offer gonadotrophin therapy to treat men and trans women and non-binary people with male reproductive organs who have hypogonadotropic hypogonadism. Only consider gonadotrophin or anti-estrogen therapy for men and trans women and non-binary people with male reproductive organs who have impaired semen parameters and no hypogonadotropic hypogonadism as part of a clinical trial. Do not offer androgens to treat semen abnormalities. Explain that the significance of antisperm antibodies is unclear and the effectiveness of systemic corticosteroid treatment for antisperm antibodies is uncertain. Do not offer antibiotic treatment to treat leukocytes in the semen unless there is an identified infection because there is no evidence that this improves pregnancy rates. Do not offer supplements, antioxidants, or medical treatments to improve sperm DNA integrity, fragmentation. Azoospermia. Offer men and trans women and non-binary people with male reproductive organ surgical correction or surgical sperm retrieval to treat obstructive azoospermia. When deciding which treatment to offer, take into account the following factors. A female fertility factors, for example, age, ovarian reserve, tubal patency, and ovulatory status. The obstructive interval if known. The risks and benefits of the surgical intervention. The person's preference. Offer surgical sperm retrieval to manage non-obstructive azoospermia. When carrying out surgical sperm retrieval for non-obstructive azoospermia, see Recommendation 1.25.2, consider microscopic testicular sperm extraction. Y chromosome microdeletions. Do not offer surgical sperm retrieval in the presence of Y chromosome ZF or B microdeletion. Reduce sperm DNA integrity. Do not offer surgical sperm retrieval as a way to improve outcomes for men and trans women and non-binary people with male reproductive organs who have non-azoospermia and reduced sperm DNA integrity, elevated fragmentation levels. Varicocele. Consider radiological or surgical treatment, taking into account female fertility factors for men and trans women and non-binary people with male reproductive organs who have varicocele detected on clinical examination and who are trying to conceive spontaneously and have reduced semen parameters. Ejaculatory failure for men and trans women and non-binary people with male reproductive organs who have ejaculatory failure. Identify the cause to determine the most appropriate and least invasive method of managing the issue. Management of female factor fertility problems. Hypogonadotropic hypogonadism. Advise women and trans men and non-binary people with female reproductive organs who have hypogonadotropic hypogonadism and anovulatory infertility that they may improve their chance of regular ovulation, conception, and an uncomplicated pregnancy by increasing their body weight to reach a healthy weight if they have a body mass index of less than 18.5 kilograms per square meter and or moderating their exercise levels if they undertake high levels of exercise. Offer gonadotrophins with luteinizing hormone activity or gonadotrophin-releasing hormone to induce ovulation in women and trans men and non-binary people with female reproductive organs who have hypogonadotropic hypogonadism. Hypothalamic pituitary ovarian dysfunction, predominantly PCOS. The recommendations in this section have been removed because NICE is developing a guideline on polycystic ovary syndrome. Ovulatory disorders due to hyperprolactinemia. Offer K-Bergolin to treat ovulatory disorders due to hyperprolactinemia. Monitoring ovulation induction during gonadotrophin therapy. Inform women and trans men and non-binary people with female reproductive organs who are offered ovulation induction with gonadotrophins about the risk of multiple pregnancy and ovarian hyperstimulation before starting treatment. Use ovarian ultrasound monitoring to measure follicular size and number as an integral part of gonadotrophin therapy to reduce the risk of multiple pregnancy and ovarian hyperstimulation. Tubal surgery. Tubal surgery for mild tubal disease. Consider tubal surgery as a treatment option for mild tubal disease in centers where appropriate expertise is available. Tubal catheterization. Consider fallopian tube catheterization by hysteroscopic or radiological guidance to treat subfertility due to proximal tube obstruction after discussing the risks and benefits of other options, including in vitro fertilization. Surgery for hydrosalpinges before IVF. Offer laparoscopic salpingectomy or tubal occlusion to treat hydrosalpinges before IVF. Consider aspiration to treat hydrosalpinges close to the time of oocyte retrieval if there is a high risk of complications from laparoscopic surgery. Uterine surgery. Offer hysteroscopic adhesiolysis for women and trans men and non-binary people with female reproductive organs with amenorrhea who are found to have intrauterine adhesions because this is likely to restore menstruation and improve the chance of pregnancy. Endometriosis. The recommendations in this section should be read in conjunction with NICE guideline on endometriosis. Discuss the following options with women and trans men and non-binary people with female reproductive organs who have endometriosis. Expectant management for up to 2 years, including the time already spent trying to conceive before assessment. A surgical treatment of endometriosis, in line with the section on management of fertility, is a priority in NICE guideline on endometriosis. If the woman, trans man, or non-binary person with endometriosis has not conceived during 2 years of expectant management or after surgical treatment, or if expectant management or surgical treatment, or both, is not appropriate, discuss the fertility treatment options and consider up to 4 cycles of intrauterine insemination with ovarian stimulation using gonadotrophins before offering IVF treatment, if appropriate, or offer IVF treatment. See the section on access criteria for IVF. Explain the potential risks and benefits of each option and take into account the person's individual preferences and circumstances during discussions. When discussing fertility with women and trans men and non-binary people with female reproductive organs who have endometriosis, take into account the length of time they have been trying to conceive, the symptoms and severity of the endometriosis, their age, their ovarian reserve, any male factor fertility issues, unstimulated intrauterine insemination. Offer 12 cycles of unstimulated IUI, providing there are no contraindications, before considering in vitro fertilization for people who are unable to or would find it very difficult to have vaginal intercourse because of a clinically diagnosed physical disability or psychosexual problem. Couples where the partner with male reproductive organs has azoospermia and surgical sperm retrieval is not suitable or has been unsuccessful, and they wish to use donor sperm treatment. For women and trans men and non-binary people with female reproductive organs who are using donor insemination and have not conceived after 6 cycles, offer 6 cycles of unstimulated donor IUI, providing there are no contraindications and no suspected or known clinical causes of infertility, before considering IVF. Unexplained fertility problems in people trying to conceive through unprotected vaginal sexual intercourse. Unexplained fertility problems. Advise people with unexplained fertility problems who are having regular unprotected vaginal sexual intercourse to try to conceive for a total of 2 years before treatment. Do not offer ovarian stimulation as a standalone treatment for unexplained fertility problems. For people with unexplained fertility problems who have tried to conceive for 2 years through regular unprotected vaginal sexual intercourse, discuss the treatment options, including the benefits, risks, and their individual preferences, and a before in vitro fertilization treatment, consider up to 4 cycles of intrauterine insemination with ovarian stimulation using gonadotropins. Or offer IVF treatment, see the section on access criteria for IVF. Assess criteria for IVF. When considering IVF as a treatment option for fertility problems, discuss the risks and benefits of IVF in accordance with the current Human Fertilization and Embryology Authority Code of Practice. Take ovarian reserve into account when discussing the option of IVF treatment. See Recommendation 1.18.4 in the section on ovarian reserve testing. Offer IVF treatment to women and trans men and non-binary people with female reproductive organs who have not yet reached their 42nd birthday, if there is a diagnosed cause of infertility for which other treatments are not suitable or have not been successful, or they have unexplained fertility problems and have not conceived after 2 years of regular unprotected vaginal intercourse, with or without intrauterine insemination, or they have not conceived after 12 cycles of artificial insemination, where 6 or more cycles are by IUI. Inform people that normally, a full cycle of IVF treatment, with or without intracytoplasmic sperm injection, should comprise 1 episode of ovarian stimulation and the transfer of any resultant fresh and frozen embryos. Healthcare providers should define a cancelled IVF cycle as one where an egg collection procedure is not undertaken. Take into account cancelled cycles due to low ovarian response when considering if further IVF treatment is suitable. If the woman or trans man or non-binary person with female reproductive organs is under 40 years and meets the criteria in Recommendation 1.39.3, offer an initial 3 full cycles of IVF treatment. If they reach their 40th birthday without conceiving, complete any current full cycle of IVF but do not offer any more cycles. If the woman or trans man or non-binary person with female reproductive organs is under 40 years and has not conceived after 3 full cycles of IVF treatment, discuss the probability of success and the implications of more treatment. And consider up to 3 further full cycles of IVF treatment. If they reach their 40th birthday without conceiving, complete any current full cycle of IVF but do not offer any more cycles. If the woman or trans man or non-binary person with female reproductive organs is under 40 and has previously had self-funded IVF treatment, do not rule out access to NHS-funded IVF treatment, but count any previous full IVF cycle, whether self-funded or NHS-funded, in the total number of full cycles offered by the NHS. If the woman or trans man or non-binary person with female reproductive organs is 40 or 41 years, meets the criteria in Recommendation 1.39.3 and has not had IVF treatment before, offer 1 full cycle of IVF treatment. Procedures used during in vitro fertilization. Pre-treatment. For recommendations on pre-treatment, see Part B on pre-treatment therapies in the European Society of Human Reproduction and Embryology, ESHIE, Guideline on Ovarian Stimulation for IVF OICSI. Do not offer endometrial scratch as a pre-treatment means of improving the outcome of IVF. Do not offer hysteroscopy as a pre-treatment means of improving the outcome of IVF. If uterine or endometrial abnormalities are suspected, see Recommendation the 18th of January 16 in the section on investigation of suspected tubal and uterine abnormalities. Endometrial receptivity testing. Do not offer endometrial receptivity testing as a treatment add-on for embryo transfer. This includes both gene expression analysis, for example, endometrial receptivity array, and microbiological analysis, for example, endometrial microbiome metagenomic analysis, analysis of infectious chronic endometritis. Immunological treatments. Do not use immunological agents, including intralipids, intravenous immunoglobulins, or steroids, glucocorticoids, as part of fertility treatment. Pituitary suppression and controlled ovarian stimulation. For recommendations on pituitary suppression and controlled ovarian stimulation, see Part C on pituitary suppression and ovarian stimulation in the ESHIE Guideline on Ovarian Stimulation for IVF OICSI. Monitoring during ovarian stimulation. For recommendations on monitoring during ovulation stimulation, see Part E on monitoring in the ESHIE Guideline on Ovarian Stimulation for IVF OICSI. Triggering ovulation and luteal phase support. For recommendations on triggering ovulation and luteal phase support, see Part F on triggering ovulation and luteal support in the ESHIE Guideline on Ovarian Stimulation for IVF OICSI. Preventing ovulation hyperstimulation syndrome. For recommendations on preventing ovulation hyperstimulation syndrome, see Part G on prevention of OHSS in the ESHIE Guideline on Ovarian Stimulation for IVF OICSI. Clinics providing ovarian stimulation with gonadotropins should have protocols in place for preventing, diagnosing, and managing OHSS. Oocyte retrieval. Offer conscious sedation for transvaginal retrieval of oocytes because it is a safe and acceptable method of providing analgesia. Do not offer follicle flushing before oocyte retrieval if there are at least 3 follicles, because this procedure does not increase the number of oocytes retrieved or pregnancy rates, and it increases the duration of oocyte retrieval and associated pain. Embryo selection strategies. Do not offer pre-implantation genetic testing for aneuploidy, PGTA, as part of fertility treatment to improve live birth rates. Embryo transfer strategies. Do not offer assisted hatching, because it has not been shown to improve pregnancy rates. Offer ultrasound-guided embryo transfer during IVF because this improves pregnancy rates. Replacement of embryos into a uterine cavity with an endometrium of less than 5 mm thickness is unlikely to result in a pregnancy and is therefore not recommended. Provide information that bed rest of more than 20 minutes duration following embryo transfer does not improve the outcome of IVF treatment. Evaluate embryo quality at both cleavage and blastocyst stages, according to the Association of Reproductive and Clinical Scientists and UK National External Quality Assessment Service embryo grading scheme. When considering the number of fresh or frozen embryos to transfer in IVF treatment. A maternal age under 37 years. In the first full IVF cycle, use single embryo transfer. In the second full IVF cycle, use single embryo transfer if 1 or more top-quality embryos are available. Consider using 2 embryos if no top-quality embryos are available. In the third full IVF cycle, transfer no more than 2 embryos. A maternal age 37 to 39 years. In the first and second full IVF cycles, use single embryo transfer if there are 1 or more top-quality embryos. Consider double embryo transfer if there are no top-quality embryos. In the third full IVF cycle, transfer no more than 2 embryos. A maternal age 40 to 41 years. Consider double embryo transfer. If IVF treatment is with donor eggs, use an embryo transfer strategy that is based on the age of the donor. Do not transfer more than 2 embryos during any one cycle of IVF treatment. Where a top-quality blastocyst is available, use single embryo transfer. When considering double embryo transfer, discuss the risks of multiple pregnancy associated with this strategy. Offer cryopreservation to store any remaining good quality embryos after embryo transfer. Advise women and trans men and non-binary people with female reproductive organs who have regular ovulatory cycles that the likelihood of a live birth after replacement of frozen, thawed embryos is similar for embryos replaced during natural cycles and hormone-supplemented cycles. Intracytoplasmic sperm injection. Offer ICSI using surgically retrieved sperm or frozen, thawed oocytes. Consider ICSI. Or if the partner with male reproductive organs has abnormal semen parameters, taking into account the severity. Or if a previous in vitro fertilization, IVF, treatment cycle has resulted in failed fertilization or a very low fertilization rate. Do not use ICSI for non-male factor fertility problems if the semen parameters are normal. Do not use intracytoplasmic morphologically selected sperm injection, IMSI, as an adjunct to ICSI. Do not use physiological intracytoplasmic sperm injection, PICSI, in preference to standard ICSI. Donor insemination. Medical indications for donor insemination. The use of donor insemination is considered effective in managing fertility problems associated with the following conditions. Obstructive azoospermia. Non-obstructive azoospermia. A severe deficits in semen quality in couples who do not wish to undergo intracytoplasmic sperm injection. Consider donor insemination in conditions such as where there is a high risk of transmitting a genetic disorder to the child, where there is a high risk of transmitting infectious disease via the semen to the child or partner with female reproductive organs, a severe rhesus ISO immunization. Before starting treatment by donor insemination, confirm ovulation. Offer tubal assessment before treatment if there is a history is suggestive of tubal damage. Offer donor sperm intrauterine insemination in preference to intracervical insemination because it improves pregnancy rates. Oocyte donation. Medical indications for oocyte donation. The use of donor oocytes is considered effective in managing fertility problems associated with the following conditions. A premature ovarian insufficiency, including following treatment. A gonadal dysgenesis, including Turner syndrome. A certain cases of in vitro fertilization, IVF, treatment failure. Also consider oocyte donation in certain cases where there is a high risk of transmitting a genetic disorder to the child. Offer oocyte donors information regarding the potential risks of ovarian stimulation and oocyte collection. Fertility preservation for medical indications. Fertility preservation. Discuss fertility preservation as an option with people who are preparing for medical treatment or who have a medical condition that is likely to impair their fertility. For people who need urgent treatment, this discussion should take place at the earliest possible opportunity. When deciding whether to offer fertility preservation, take into account the following factors: the person's diagnosis, the planned treatment, the likely outcome of subsequent fertility treatment, the person's prognosis following the treatment of the condition, the likely viability of stored or post-thawed material. For NHS-funded fertility preservation, do not apply the eligibility criteria used for conventional fertility treatment, including the lower age limit. Inform people who are considering fertility preservation that eligibility criteria for assisted conception in an NHS setting will apply when it comes to using stored material. Offer sperm cryopreservation to men and boys, and trans women and non-binary people with male reproductive organs who are of reproductive age and who are preparing for medical treatment or who have a medical condition that is likely to make them infertile. Offer oocyte or embryo cryopreservation, as appropriate, to women and girls, and trans men and non-binary people with female reproductive organs who are of reproductive age and who are preparing for medical treatment or who have a medical condition that is likely to make them infertile. Consider ovarian tissue cryopreservation when oocyte or embryo cryopreservation is not feasible, for example, in girls before puberty. Organize follow-ups at least every 5 years with people who have had their material preserved to determine whether or not there is a need to continue NHS-funded storage. Offer continued NHS-funded storage for people who remain at continued significant risk of infertility, in line with legislation on consent. Long-term safety of assisted reproductive technologies. Long-term health outcomes of ovulation induction and ovarian stimulation. Give people who are considering ovulation induction or ovarian stimulation up-to-date information about the long-term health outcomes of these treatments. Inform people who are offered ovulation induction or ovarian stimulation that no direct association has been found between these treatments and invasive cancer, and no association has been found in the short to medium term between these treatments and adverse outcomes, including cancer, in children born from ovulation induction, and information about long-term health outcomes is still awaited. Limit the use of ovulation induction or ovarian stimulation agents to the lowest effective dose and duration of use. Long-term health outcomes and safety of in vitro fertilization. Give people who are considering IVF treatment, with or without intracytoplasmic sperm injection, ICSI, up-to-date information about the long-term health outcomes, including the consequences of multiple pregnancy, of these treatments. Inform people that, while the absolute risks of long-term adverse outcomes of IVF treatment, with or without ICSI, are low, a small increased risk of borderline ovarian tumors cannot be excluded. Inform people who are considering IVF treatment that the absolute risks of long-term adverse outcomes in children born as a result of IVF are low. Limit drugs used for controlled ovarian stimulation in IVF treatment to the lowest effective dose and duration of use.